Please test.
Okay, Doc, wait.
Who is like to do the final test? Please do ahead. Can you make a full screen?
Okay.
Okay, perfect.
Okay, perfect. Thank you, sir.
Thank you. Okay, stop here.
Can
Yeah,
you hear my voice?
Yeah, loud and clear. No problem.
Okay.
Thank
Thank you, sir. Thank you so much.
Yeah, thank you. Please stop sharing.
I think it's time now to start.
Yeah, time. Well, good afternoon, everyone. I think we can start this program. I'm Dr. Lee. On behalf of the Asia Pacific Society of Cardiology, I would like to welcome all of you to today's APSC platform of cardiovascular disease series. Our topic today is unsolved or debating issue in interventional management of acute the coronary syndrome. Today we are honored to have a distinguished speaker from across the Asia Pacific region, Singapore, Thailand, Pakistan, India, Indonesia, and Taiwan, who will share their insight and perspective on this important, sometimes debatable topic. I would also like to acknowledge my co-chair, Professor Jawad Sayo from Pakistan, Vice President of APSC and the Executive Director of SICBD, for joining me in leading this session. So I think we can start this program. I just want to remind each speaker has 20 minutes presentation, and then we have a Q&A, 5 minutes. So let's begin our first session with Dr. Luo from Singapore, who will discuss the beta blocker after myocardial infarction in patients without heart failure. So, Dr. Luo, are you online?
Yes, I am. Okay, I'm going to share screen now.
Yeah. You had mentioned you maybe leave early, so it's okay. So you can start your speak. Then we will have a 5 minutes Q&A. Thank you.
Okay, thank you very much. Hi, everyone. I'm Shi Tong from Singapore. I work at the National Heart Centre, Singapore. And it's my pleasure to be here at the webinar to discuss about beta blockers after myocardial infarction in patients with heart failure, pros and cons. So a great thanks to the organizers for inviting me to the webinar, and very happy to have a fruitful discussion with everyone on this topic that is very interesting. Okay, so the background is that beta blockers were the cornerstone of post-MI care since the 1980s, and there's been several RCTs that demonstrated that beta blocker therapy significantly reduce all-cause mortality as well as cardiovascular mortality in post-MI patients. So these are some of the important trials that were done. And you can see that most of these trials were done in the 1980s, and that predates the reperfusion era. And it is understandable as to why most of us feel that beta blockers are important and help patients, because mechanistically, beta blockers reduces the myocardial oxygen demand and reduces the patient's likelihood of having cardiac arrhythmias. And with the anti-remodeling effects of beta blocker, we all agree that there is a role for beta blockers in patients post-MI. And that's what the guidelines say as well. However, after the reperfusion era, with newer thrombolytic agents and invasive strategies such as percutaneous coronary intervention, it really changed the landscape and helped to improve the cardiovascular mortality of our patients. And in the current time, whereby the cardiovascular mortality rates of patients post-MI have been drastically reduced with the reperfusion therapy, the benefit of beta blocker now is becoming less clear. And in particular, the effectiveness of beta blockers in patients with preserved ejection fraction is currently being challenged. So this is a pictorial diagram of the RCTs that's been performed in the pre-reperfusion era. And you can see that there's strong positive association in terms of the benefit of beta blockers in helping all-cause mortality, cardiovascular mortality, and morbidity. And in the reperfusion era, which is the part on the right-hand side, you can see that with the more current trials, such as reduced AMI, the positive association is less clear. And in fact, some of the trials actually showed no association. So we'll discuss that in the next couple of slides. So what did the guidelines say? So in the latest ACC/AHA guidelines that's published in February this year, it has acknowledged the reduced AMI trial to be a trial that raised questions about the benefit of beta blockers following hospitalization of patients with ACS. However, at that point in time, reduced AMI was one of the first trials that have came out. So the area of study then was unclear, and therefore, in terms of recommendation, it's still class 1A for patients to have beta blockers initiated to reduce the risk of infarction and ventricular arrhythmias post-ACS. So that is the ACC/AHA guidelines. Then the ESC guidelines that was published 2 years ago also acknowledged that the utility of beta blockers in patients with LVEF more than 40% is less well established than as compared to patients with LVEF less than 40%. So you can see in the table here, I'm not sure if you can see my pointer, but let's see whether if I can get the pointer out. Yeah, so you can see that for patients with LVEF less than 40%, the recommendation is class 1A for initiation of beta blockers, whereas for patients with more robust LVEF, the recommendation is class 2A. Yeah, so that is the difference in the ESC guidelines. And this is hot from the most recently published meta-analysis. So the beta blocker trial list collaboration study group has looked into a lot of the RCTs that's been published in the past 2 years about the efficacy of beta blockers in patients who have had a myocardial infarction but with preserved ejection fraction. And this is published in the New England Journal of Medicine just 2 weeks ago. So let's take a closer look at this meta-analysis. So a total of 17,801 patients with preserved ejection fraction were included from 5 trials. So these 5 trials are the Reboot trial, the Reduced AMI trial, the BETAMI trial, the DAMBROC trial, as well as the Capital RCT trial. And when we look at the demographics of patients that's recruited in these 5 trials, the baseline characteristics of the study population is well balanced, as you can see in the table on the right. The inclusion criteria are patients with preserved LVEF, and they've excluded patients with any indication for beta blockers outside of myocardial infarction, and those who unfortunately cannot tolerate beta blockers due to contraindications. And the mean follow-up period was 3.6 years. So in terms of the primary composite endpoint, which is a combination of death from any cause, myocardial infarction, as well as heart failure, you can see on the diagram here that whether be it patients on beta blockers or without beta blockers, there's not too much of a difference. And treatment with beta blockers is not associated with any improvement in terms of death from any cause, myocardial infarction, as well as heart failure, as determined by the meta-analysis. And if I could summarize all the trials that's been done in the past couple of years, you can see that most of the trials that actually show beta blocker is superior are trials whereby the LVEF is 40 to 49%. And in trials that included only patients with LVEF of more or equals to 50%, and as illustrated in the meta-analysis that I've showed just now, it has not been proven that beta blocker therapy is superior. So that is the interesting aspect that we have noted in the past couple of years. And if we look at the pros and cons of having beta blockers on board, of course, we agree that beta blockers have anti-arrhythmic protective effect. It helps to reduce angina for our patients, reduce recurrent ischemia, and if the patient has coexisting atrial fibrillation or microvascular dysfunction, beta blockers can come in very effectively and help these patients in terms of their quality of life. However, the problem or the side effects of beta blockers are also something that we need to consider. And a lot of our patients do mention to us that after taking beta blockers, they become increasingly more fatigued. They have reduced exercise tolerance. Some of their heart rate becomes rather low. And in diabetic patients, we do know that beta blockers may mask symptoms of hypoglycemia. And with polypharmacy adherence as a potential issue, whether if there is a role to have our patients being on beta blockers is something that we should discuss. So observations, adherence drops over time. Our patients tell us that they're on a cocktail of medications and they feel that the pill burdens are very high. Some patients may discontinue beta blockers due to side effects, as per what I've mentioned just now. And we know that patients who are asthmatics may have bronchospasm problem with beta blockers. That's something also to consider. And in a patient with diabetes and hypoglycemic, beta blockers may mask the hemodynamic signs that's commonly noted, such as tachycardia. And of course, some patients also tells us about issues of sexual dysfunction as well as erectile dysfunction while being on beta blockers. So these are all things that affects the patient's quality of life. So something that we would want to consider. So currently, the momentum is swinging towards selective use. So I agree that beta blockers matter still after MI, and they have a greater implications in patients, especially those with reduced LVEF, as well as those with mildly reduced LVEF. In patients with preserved LVEF, a blanket approach is no longer supported by the current evidence that we have. So whether to continue beta blocker in a patient with normal ejection fraction should be made on an individual basis, weighing the current literature evidence against the patient's other comorbidities, such as AF, for example. So a one-size-fits-all approach for beta blockers no longer holds. And I think a lot of us agree that for patients with angina, for patients with arrhythmia, beta blockers comes in really handy and it improves these patients' quality of life. However, if the patient's EF is preserved, they are very asymptomatic, no arrhythmias, I think it's not unreasonable to hold off beta blockers looking at the current evidence that we have. And the optimal duration of therapy for these patients remains uncertain. And if the patients who have been initiated on beta blockers feels well and wants to discuss with you about potentially reducing some of the medications that they are on, I do think that it might be reasonable for a discussion to discontinue beta blockers to be made on a case-by-case basis. So these are the references, and I'm happy to take questions. Thank you very much.
Thank you. Thank you. Very detailed and complete speak to summarize beta blocker treatment in cardiac infarction. I think it's now the new concept is ejection fraction is not very low. Normal ejection fraction post-overnight patient maybe beta blocker is not very useful for this patient. I think the main conclusion is this point. Is there any question from our audience? I think we have 10 minutes long, but if we don't have more questions, we can move to next topic. Is there any question from the audience? I don't know. In the Singapore,
Professor Ling asked a question about residual ischemia and the role of beta blockers for residual ischemia. I think the role of beta blocker in this setting is robust, is strong. So if a patient post PCI still has angina symptoms and there is residual ischemia that is noted, there is a role for beta blockers in these population. Yeah.
the second question, why the
time frame of beta blockers?
Yeah.
So I think it depends on the situation. So with the most recent meta-analysis that came out, so if a patient is well asymptomatic, EF is preserved, no risk of arrhythmias, meaning to say that they don't have, a atrial fibrillation or VTVF or NSVTs that's noted on the telemetry or Holter, it is reasonable to discuss with the patient about discontinuing beta blockers. But of course, like what Professor Lin has mentioned, if they have residual ischemia, if they have angina symptoms, then the beta blockers does help in terms of improving symptoms for these patients. So ultimately, it's on an individual case basis, on a case-by-case basis for our patients.
Also have a more question. So also have one question about the Minoca, about beta blocker. Can you give me more detailed explanation about beta blocker for the Minoca?
Yeah, so I definitely think that there is a role for beta blockers in treatment of microvascular dysfunction. So Minoca, Inoca, if patients have angina, microvascular dysfunction, the role of beta blockers is pretty robust, and we would advocate for beta blockers to be given to these patients. Yeah. And I think there's another question about repeating echo to see the ejection fraction. I think what was studied in the meta-analysis are the echo that was done when the patient is admitted for ACS. So that was the initial LVEF of the patient. So if the initial LVEF of the patient is preserved, perhaps not giving these patients beta blockers is okay, as per illustrated in the meta-analysis. But if the patient's LVEF is impaired, then definitely I think the guidelines is very clear that there is a role for beta blockers to be given for these patients.
Yeah. Professor Lin also have a question about the procedure and the silent ischemia. I think this is a very important issue because sometimes ACS patient with ACS maybe have a multi-vessel disease and initially you just manage the top region only and the non-top region stenosis ischemia you cannot manage initially. So the medication is very important. So how about the question of one Professor Lin? What is your answer?
So I think beta blockers we need to look at the patient's LVEF. So if a patient has microvascular multi-vessel disease and his LVEF is poor, anything that is less than 50%, there is definitely a role of beta blockers for this patient, and evidence is pretty strong. If the patient's LVEF is preserved and they're completely asymptomatic, there's no arrhythmias, no angina symptoms, I think it's on a case-by-case basis, individualized approach to discuss with the patient whether to continue with the beta blockers or consider temporarily discontinuing it and see how the patient do. But definitely for patients whose LVEF is impaired, the role for beta blockers is strong. It has a mortality benefit, and it helps in terms of their heart failure readmissions.
Yeah.
Hi, Aaron. This is Dr. Kumar from Pakistan. Just I want to clear certain confusions in my mind. That what about the patients who having low ejection fraction, and you started beta blockers, and now his ejection fraction has improved. For how long then you will continue beta blockers, and what exactly will you suggest the time frame then you will start decreasing or complete stoppage of the beta blockers?
So I think, thank you for your question. So I think in the heart failure trials that has been done, it has been illustrated that for patients with HFrEF, and if they go directed medical therapy, HFrEF and EF subsequently normalizes with goal-directed medical therapy, and if we reduce or remove of their goal-directed medical therapy, sometimes their LVEF drops subsequent to that. So by the heart failure guidelines, I think the recommendation is that for patients with poor LVEF who are on goal-directed medical therapy, to continue to give the goal-directed medical therapy for these patients, even if their LVEF has subsequently normalized. So in terms of patients post-AMI, I would say that it should, by extrapolation, follow the same concept that if the patient's LVEF is poor on the initial admission for AMI, and if we are to initiate goal-directed medical therapy for these patients, then we should continue these patients on the goal-directed medical therapy, even if the LVEF subsequently returns back to normal. The only controversial or the part that we are discussing right now is if actually the MI is treated very early on, meaning to say that in terms of myocardial ischemia, in terms of myocardial damage for these AMI patients is quite low in a sense that after revascularization, when we check their echo, the LVEF is actually preserved. So perhaps in these group of patients whereby the MI is small and revascularized early, such that they are fully revascularized with a good preserved LVEF in the index admission, perhaps beta blockers may not help as much. But if these patients do have a reduced LVEF in the index admission for we would recommend for the beta blockers to be continued and not to be stopped.
Thank you.
I don't see any question anymore. So to save time, we can move to the next topic. Thank you Dr. Luo very detailed speech and a very excellent answer for all the questions. So I want to Dr. Professor Jowa Akaba style. Can you share the
Thank you very much. Yeah.
share the
Thank you very much.
yeah.
Dr. Hassan, Dr. Lee, it was great talk, and definitely we all want to know about beta blocker. This is a magic drug post MI, and there are positive, negative things are coming from time to time. That's how the science is going on. Now, moving to next speaker, he's a colleague from Thailand. Is Dr. Chayasiri Vanlapokorn. Sorry if I mispronounced the name. So, Dr. Chayasiri is from Thailand, lecturer and interventional cardiologist. He's a lecturer and interventional cardiologist from King Chulalongkorn Memorial Hospital, Bangkok, Thailand. He's going to talk on colchicine after acute and chronic coronary syndrome, pros and cons. This is a bit a debatable topic, and we are going to learn from experience of a doctor from Thailand. Thank you.
Thank you. Good morning, all professors and all the audience. Can you see my slide? All right, so it is my honor to join this APSC session, and today my topic is about the colchicine in patients with CAD, both acute coronary syndrome and chronic coronary syndromes. So let me start with a brief history of colchicine. So the colchicine is one of the oldest remedies which is still in use today, especially for the patients who have the gouty arthritis. It is derived from a plant which is called the Colchicum autumnale. And the Colchicum autumnale history as an herbal remedy for the joint pain goes back at least to the 1500 BC. It was documented in the Egyptian manuscript, the Ebers Papyrus, which I think it might be the first medical textbook. However, at that time, the 1500 BC, at the time, colchicine was not isolated yet. It was until 18th century. There were two French scientists who isolated colchicine from the roots of the Colchicum autumnale. On the slide, it is the timeline of 5 key RCTs investigating colchicine in CAD patients, from Lodoco in 2013 to Clear Synergy or Clear Oasis in 2024. So then I'm going to summarize these 5 trials. So let's begin with the Lodoco trial. This trial included 532 CCS patients. They were randomized to receive either colchicine 0.5 milligram once daily versus placebo. The mean age was about 66 to 67 years old. 90% were male, 10% were female, 30% of them were diabetic. About 1/4 of them had a history of acute MI or anterior angina, and around 75 to 80% of them underwent revascularization. So the primary outcome occurs in 5.3% in colchicine arm and 16% in the control arm, with the hazard ratio of 0.33 and the p-value of less than 0.001. So this is a positive trial for colchicine in CAD patients. And the result was mainly driven by the ACS events, especially the non-stent related ACS. So that is the first one, the LODOCO trial. So the next one is the cohort trial, which was published in New England Journal of Medicine in 2019. So 4,745 post-MI patients were randomized to receive either colchicine or placebo. The mean age was about 60 years old. Around 80% of them were male, 20% of them were female. 20% of them were diabetic, and about 93% of them underwent revascularization with PCI. The primary endpoint occurred in 5.5% of the patients in the colchicine arm, as compared with 7.1% of those in the placebo arm, with the hazard ratio of 0.77 and a p-value of 0.02. Again, this is a positive trial for colchicine in CAD patients. The hazard ratio were 0.84 for death from cardiovascular causes, 0.83 for resuscitated cardiac arrest, 0.91 for MI, 0.26 for stroke, and 0.5 for revascularization. So from these clinical outcomes, only stroke and revascularization seems to be statistically significant difference. The next one is LODOCO-2 trial, which was published in New England Journal of Medicine in 2020. 5,522 CCS patients were randomized to receive either colchicine or placebo. The mean age was about 65, and 85% were male, 15% were female. 84% of patients has a history of prior ACS, and most of them occur more than 2 years prior to randomization. The median follow-up period was about 28 months, and the primary outcome occurred in 6.8% in the colchicine arm and 9.6% in the placebo arm, with the hazard ratio of 0.69 and the p-value of less than 0.001. So most of the secondary outcomes in the colchicine arm tends to be superior to the placebo arm. So the result from LODOCO-1, LODOCO-2, and cohort trials show the benefit of colchicine in CAD patients. So let's move on to another trial, which is a negative trial, the COPS trial. Around 800 ACS patients were included and randomized to receive either colchicine versus placebo. For the COPS trial, in colchicine arm, the colchicine was prescribed 0.5 milligram twice daily for 1 month, and then once daily for another 11 months. The mean age was about 60 years old. And again, most of them were male, around 80%. About half of them were diagnosed with STEMI. So at the 1 year follow-up, there were 24 events in the colchicine arm, compared with 38 events in the placebo arm, which was not statistically significant difference between both groups. Moreover, the primary outcome was not different between both groups, and there was a higher rate of total death in the colchicine group compared to the placebo. However, the rate of ACS was lower with colchicine arm. And last but not least, the clear synergy or clear OSIS 9 trial. This is the largest trial investigating the benefit of colchicine in CAD patients. This trial includes around 7,000 patients with acute MI undergoing PCI. They were randomized to receive either colchicine or placebo. The mean age was about 60 years old. And again, most of them were male, around 80%, 20% were female. And most of them, 95%, were diagnosed with STEMI. For about the CRP level at the baseline, there was no difference between the CRP level from colchicine arm and the placebo arm. However, at the 3-month follow-up, the CRP level in the colchicine arm tends to be lower than the placebo arm. There was no statistically significant difference between both groups in terms of primary outcomes, which was the composite of CV death, MI, stroke, and revascularization. As well as the secondary outcome, there were no difference between both groups, except the non-CV death, which tends to be just a little bit lower with colchicine, 1.3% versus 1.9% in the placebo arm. And obviously, the rate of diarrhea was higher in patients with colchicine, 10% versus 6% in the placebo arm, with the p-value of less than 0.001. So right now, there are 3 positive trials for colchicine in CAD patients, and there are also 2 negative trials. So how can we make a decision? So let's do the meta-analysis. So from 16 studies with more than 20,000 CAD patients, both ACS and CCF, colchicine does not reduce the relative risk of the all-cause mortality. As you can see from this slide, the relative risk was about 0.97, and colchicine does not reduce the risk of cardiovascular death as well. The relative risk was about 0.98. However, it can reduce the risk of MI with the relative risk of 0.74, and it also reduced the risk of revascularization with the relative risk of 0.72. So what do the current guidelines recommend? From ESC guideline, colchicine is recommended in class 2B for ACS patients. This is from ESC guideline 2023. And for CCS patients, it is class 2A from the guideline in 2024. For ACC and AHA guidelines, colchicine is recommended in class 2B for ACS patients. This is in 2025. And it is class 2B for CCS patients. And this is from the guideline in 2023. The results of the CLEAR OC7 trial were not taken into account of this guideline. So I think the revise of these guidelines, it might change, because the CLEAR OC9 trial, it is a negative trial for colchicine in CAD patients. So this is my last slide. My practice, this is my practice. So in my practice, colchicine is rarely prescribed for patients with CAD, because I think the clinical benefit remains uncertain, and there is a potential for drug-to-drug interactions, especially with statins. I may consider in some patients, like in patients with recurrent MI, without any clear etiology. Like if the patient can control their risk factor very well, the A1C, the LDL level was perfect, and they still have the MI, I might consider to prescribe colchicine. So thank you for your attention, and please feel free to ask any question. Thank you.
Hi, this is Dr. Kumar from Pakistan. Yeah, just very nice presentation, and I love to hear you about the colchicine. Though this is a drug that I used to prescribe in recurrent pericarditis most of the time, but now heard that it has been promoted for the coronary artery disease as well, being the anti-inflammatory agent. But I want to just ask, what exactly do you think could be the indications? If I say you give me the crisp indications for the colchicine, the coronary artery disease, whether it is chronic or acute coronary syndrome. So how would you justify that prescribe in such patients of coronary artery disease?
So I think the mechanism, the main mechanism of colchicine is the anti-inflammatory treatment. So I might consider colchicine in CAD patients who have the repeat events like multiple times of MI without any clear etiology, like if they can control their risk factor very well, and if the inflammatory marker is a little bit elevated, like the CRP may be high, I might consider colchicine. But to be honest, in my practice, I do not prescribe that a lot because I think in Asian population, our patients tend to have higher higher chance to develop the side effect from the statin. So if I prescribe colchicine together with like simvastatin, atorvastatin, most of the time my patient they do complain about the muscle pain, the side effects. So I rarely prescribe the colchicine. So before I prescribe, I would look for every single risk factor that that I can control, and I might consider to do the test for the inflammatory markers.
Thank you. Thank you.
Hola, Paco. I'm Dr. Lee, and we also have some question from some. I see a question from Professor Lin that mentions. Can we see the level of high sensitivity CRP level to determine to use colchicine or not? Can you hear?
Yes.
Can you?
Actually, I would say that most of the clinical trial that I already presented, they did not include the CRP or high sensitivity CRP level into the inclusion criteria. Except the last one, the OSIS, the clear OSIS 9, they did measure the level of CRP, but yes, most of the time, most of the clinical trials, they did not measure the level of high sensitivity. So actually, you can prescribe the colchicine even you did not do the test. But personally, if I need to prescribe, I might measure that level. If it's not high, I would not prescribe the colchicine because I think the main mechanism would be the anti-inflammatory treatment.
Is there any question? From the audience, any question from the audience? Okay, if there is no question, we can move to the next topic. And how about Professor Style? Do you want to? Can you to share this speak?
Yes, thank you very much. Now I'm inviting Dr. Mahesh Batra, who's Associate Professor at the National Institute of Cardiovascular Disease. He's going to talk on abbreviated DAPT and interventional therapy in acute coronary syndrome, pros and cons. So Dr. Batra is going to talk on this topic. Thank you.
Thank you, Professor Lee, Professor Javed Akbar Sial, Pakistan Cardiac Society, and Asian Pacific Cardiac Society for honoring me this opportunity to present for this prestigious platform and represent my institute and country. Can you just see my screen so that I can start my presentation?
Yes.
Yes, you are visible.
Thank you, everyone. So today, what I have been assigned that I should talk about the role of DAPT. Must say evolving role of DAPT in acute coronary syndrome, and what are the pros and cons of this therapy in nowadays. I don't have any conflict of interest related to this talk. Neither have industry affiliation with this talk. Patients with everybody knows that nowadays patients with acute coronary syndromes, they are always at risk of having recurrent events, and that underscores the need of a continued or sustained antithrombotic therapy for a prolonged period of time. And DAPT in this regard played a pivotal role, and they remained a cornerstone management, including the aspirin and P2Y2 inhibitors for antithrombotic management. DAPT does not only decrease the risk of stent thrombosis in patients who have undergone stenting, but it lowers the major adverse cardiovascular events in patients with acute coronary syndrome for a long period of time. But the issue with the DAPT is that for how long? The question always is evolving and investigated throughout the years for optimal duration and regimes is the subject of investigation and debate for a prolonged period of time. Though there are so many factors that impede or that can, you can say, impact the DAPT decision, whether what type of the SCS that we are dealing with, either is acute coronary syndrome, unstable angina, non-STSCS or STSCS, or what type of the stent has been actually placed. Either it was bare metal stent platforms initially used, drug-eluting stent starting from the first generation, now the fourth generation bioresorbable scaffold, or I can say abdominal surfaces. And definitely there are certain individual risk profiles that dictate us the type of the or duration of the DAPT. Either patient is having chronic kidney disease or diabetic, and definitely either the IVUS has been used in recent days to optimize the stents. So they all actually dictate the duration of the DAPT. So again, this background, novel antithrombotic strategies have been developed to achieve the balance between the risk of thrombosis and bleeding. Because this is always a question that if you give a more potent drug to decrease the risk of thrombosis, it carries the increased risk of bleeding. So that can be decreased or balanced by modulating the DAPT duration. You can shorten the duration, or you can change the composition of DAPT, or you can de-escalate. We'll see how we are evolving it. It is more than 2 decades now. The different guidelines have endorsed DAPT for different clinical indication of acute coronary syndrome. And since 2007, it is class one recommendations by European and by American Society of Guidelines. They all endorse that DAPT should at least should be continued for 1 year. So if you look at the history, it was the first cure trial in 2001 that has evolved or that has introduced the clopidogrel in ACS in post-PCI patients versus the aspirin alone. It was again the DAPT versus SEPT, and it was a dramatic, I can say, trial that has shown a drastic improvement in the major cardiovascular events and introduced clopidogrel to the market. Since then, it is cornerstone medication, one of the DAPT. Afterwards, in 2007 and 2009, two other landmarks trial came into the play that introduced the presugrel and ticagrelor into the market to reduce the rate of stent thrombosis. That was a question that the patients do develop stent thrombosis despite taking clopidogrel. So till then, there are so many trials now, more than 37 approximate trials to date has been published related to DAPT. So again, just a few words regarding the tritontomy 38, which was a landmark trial in 2007 that introduced the presugrel to the market, and that showed it was compared with the landmark, which was a landmark drug with the combination of the aspirin. So when presugrel was compared with the clopidogrel, it showed there's absolute risk reduction of approximate 2%. With the decrease in 138 events in patients who were taking the presugrel versus the clopidogrel, and hazard ratio was 0.81, very impressive numbers at the time. And again in 2009, the Plato investigators have introduced the ticagrelor, which showed versus the clopidogrel, which showed the absolute reduction of 2% primary events. So these both trials again is a summary of the all three trials that I mentioned: the Cure, tritontomy 38, and Plato, which incorporated more than 18,000 patients, which showed that with the introduction of the newer agents, there is drastic improvement in the cardiovascular death, MI, and stroke, though there's definitely there's increase in the major bleed. And these are the certain characteristics of the drug, ticagrelor being the newest one in the market, but it definitely it is now become the more than a decade it is there. So because of being a rapid onset and rapid offset action and very much tolerable and does not require conversion to body, because being an active formulation is now prescribed most of the time. So the question again remains the same nowadays, that though if you're giving the potent drug that decreases the cardiovascular events, that decreases the ischemic burden over the patient, recurrent visits, hospitalization, morbidity, but definitely there's an increased risk of the major bleeding. So one of the study was published in the 2010 that showed that in 2010 the balance should be there between the two. So the drug should be balanced. It should be equally effective and equally safe. So certain risk factors or risk score models were introduced, including the precise DAPT or DAPT. DAPT was introduced after the DAPT trial, which was done to show that for how long that you can give DAPT to decrease the risk of stent thrombosis, and it showed that if you give the DAPT for more than the standard duration or 30 months, that decreases the risk of stent thrombosis quite a lot as compared to the standard therapy. But definitely it at the increased risk of bleeding. The precise depth showed that if patients having more than 25 scores, so you should use the shorter duration of the DAPT as compared to for longer duration. So though the precise depth was there for a prolonged period of time, but it was validated in multiple studies, and it was not so much effective in detecting the you can say the number of the cases that require DAPT for how long. So again, the BART people came into the play, and that showed that if patients were at HBR, high bleeding risk, and they carry one of the major criteria or two of the minor criteria, they should be labeled as HBR, I mean the high bleeding risk. So in these patients, you should use the lower dose of the DAPT as compared to the standard doses. So that has introduced the new era, a new chapter of a conversation or investigation that will happen if you start de-escalating the medications earlier as compared to the standard duration that was described in different international guidelines. So de-escalation, I must say, that can be done at different levels. Either you want to switch the medications from the high potent drug to low potent drug, from ticagrelor to clopidogrel, or you can reduce the dose, reduce the duration from 12 months to 6 months to 3 months to 1 month, or you can de-escalate by only discontinuing the aspirin after the 1 month and continue remaining the DAPT. So different studies has been done to look into this issue. I will quote a few of them, but one of them was the SMART DAT. It was the randomized control trial, open label non-inferiority trial, and that showed that if people are being put on the DAPT for only 6 months versus the 12 months, though the overall death rate was not different between the two, but there was an increase in the number of the myocardial infarctions. Here you can see number of the myocardial infarctions here. Can you see my pointer? Okay. Yes, you can see there's a risk of the increased number of myocardial infarctions, and there's decreased risk of the bleeding if you are using the DAPT for 6 months, but definitely at the risk of increased MI and stent thrombosis. Another trial, ultimate DAPT, came into the play in 2024, was presented in SEC 2024. That incorporated 3,400 patients in which they used the ticagrelor for 1 month only versus the ticagrelor plus aspirin for 12 months. Here the aspirin was stopped prematurely after the 1 month, and that showed that treatment with ticagrelor monotherapy after the initial month post-intervention decreased the bleeding events while providing similar MACE protection as ticagrelor plus aspirin. So this trial has actually showed there's those patients who are only put on ticagrelor after PCI. They were in SCS patients who underwent PCI. If you put the patients on clopidogrel for after a 1 month only, in stopping the aspirin, that do equally well as compared to those patients who were put on the DAPT, and that showed us in this chart that there was a drastically decrease in the bleeding, bark bleeding, while there was, if you see the safety endpoints, we are always concerned with the safety endpoint, the MACE rate, major adverse cardiovascular and cerebrovascular events, that ticagrelor alone did equally well as compared to the ticagrelor plus aspirin. Another meta-analysis was published, and that showed these are the different trials of the recent approximate 15 trials that included more than 30,000 patients, and that showed that the patients who were giving the monotherapy with the potent antiplatelet did well or did the same as compared to the patients who were giving DAPT for the 12 months standard therapy. And they did well in terms of the reducing in the bleeding events. They did well in terms of the MACE rate as well. So another trial that was published in 2005, it was now presented in the ESC Congress in a couple of months ago at Madrid. That included approximate 3,400 patients, approximate 3,400 patients. And in this patient, all the lesions were treated with the latest DES, and the patients were then randomized into the two arms. One, the DAPT aspirin was potent PA2 inhibitor for the 1 year, and then after 4 days, this was a very much interesting trial that they stopped DAPT after 4 days in a treatment arm, and then they continued single PT, single antiplatelet agent for the remaining of the duration for 1 year. So there were the two primary endpoints of this new mindset trial. That one was the ischemic events, one was the assessment of the bleeding outcomes. So what they actually showed, here you can see one of the again diagram I pointed out, that it was randomized after the 4 days of the PCI into the one that took the DAPT, another group that took the only single APT. So what this new mindset trial showed, that was a very much true or you say premature stoppage of this DAPT agent, and that has resulted in increase in number of events. Here you can see there the cumulative incidence has actually drastically improved or increased in 7% of the cases versus the dual antiplatelet was 5.5%. So overall, monotherapy was not recommended in this trial, and was said that it is better to continue dual antiplatelet agents. Though what I have reviewed it, it was very much premature. It was done within 4 days of randomization. So what was the conclusion of this study? That among patients who had undergone successful PTI or ACS, potent P2Y12 monotherapy was not found to be non-inferior to dual antiplatelet with respect to composite endpoint of death and ischemic events at 12 months. There was another trial, the target first trial. It was done in same ACS patients who underwent PCI. Again, it was randomized into single platelet agent and dual antiplatelet agent. The MACE rate was same, or I can say that what I will go for the direct conclusion that among the low risk patients with ACS who had undergone early complete revasc and had completed the 1 month of dual antiplatelet therapy without complication, the potent P2Y12 monotherapy was not inferior to continued dual antiplatelet therapy with respect to occurrence of adverse cardiovascular or cerebrovascular events with the lower risk of bleeding events. So what this study says, that if a patient who continues potent antiplatelet agent DAPT for 1 month, minimum for 1 month, and then later on continue for the 11th month, versus those patients who continue for DAPT for 1 month, their decrease, it was not inferior to switch to the de-escalate to the single PT. So what exactly now guidelines say in 2025? Though this guideline actually published in April versus the dose trial that I mentioned and done in the August and September, that was presented in the international conferences, that DAPT in acute coronary syndrome remain the default strategy for 12 months. Ticagrelor and prasugrel are preferred in post-PCI patients versus the clopidogrel, and clopidogrel will be given to those patients where you think ticagrelor or prasugrel are contraindicated or not available, or patient having a history of bleeding. What happens if those patients who are at risk of higher bleeding, then you can switch to single PT after 1 month. You continue DAPT for 1 to 3 months post VCI, then you can switch to the single PT, but make sure it should be the potent one. And what about those patients who are on the triple regime for whatever the reasons, either they are having underlying baseline atrial fibrillation, LV clot, or having prosthetic valves or other indications of anticoagulation. So you can discontinue aspirin after 1 month of triple regime and then continue P2Y12 inhibitor plus oral anticoagulation for remainder of the period. And then you can, after 1 year, then you can switch to the only single agent. So what the take-home message from my side, that dual antiplatelet therapy is recommended for patients with SCS till death. Ticagrelor and prasugrel is recommended in preference to the clopidogrel in SCS who undergone PCI. Dual antiplatelet therapy, aspirin and P2 indicated for at least 12 months as a default in patients who are at not high risk of bleeding. And thank you from my side, and I would be happy to take any question from you.
Thank you, Dr. Petro. Very detailed review and review all the recent study about the short maybe the explosion treatment in the DAPT patient. Is there any question from the audience? Patrick, can you hear me? Patrick? Patrick?
Should I start if there are no questions?
Okay, Dr. Patrick, he cannot respond. So I cannot sure he was online or not. So maybe we can move to the next topic. I will invite the Dr. Professor Agrawal from India for the next topic, abbreviated after interventional therapy in coronary syndrome. Professor Agrawal, please. Thank you. I can see your slide. Yeah.
Good morning, chairpersons and the audience. Greetings from India. I'm going to take you through the journey of abbreviated DAPT in chronic coronary syndrome and try to synthesize a little bit of overlap between ACN and CCS just to present a comprehensive picture that how we look at these two syndromes. The first thing which had been spoken earlier also, you have to individualize the risk before you take a call, what kind of antiplatelet therapy you are subjecting to your patient. Let me talk some fundamentals which will drive your understanding to deeper levels, that how we choose and what we do. We are always in search of a sweet spot where ischemic events are prevented and bleeding events are minimized, and that we have to do clinically, not by means of any kind of sophisticated tools. So it's a clinical exercise. If I conceptualize, the ischemic risk goes up in first 24 hours, then keeps on going and is maintained. This is a bleeding risk, and then it is maintained at a lower level. If you look at the ischemic risk after revascularization, it is decreased but continues to be more than the bleeding risk over a period of time. Looking at the natural history of atherosclerosis, calcified plaques keeps on progressing. Non-calcified plaques don't have linear progression. They wax and wane. So is the inflammation, and so is the risk. So that is very conceptual, that the risk of atherosclerosis and inflammation is variable over a period of time. This is a slide which is taken from Compass, which talks when you follow these patients over a period of 3 years, the bleeding risk is more or less constant, while the atherosclerotic risk keeps on increasing. I must talk, when we are talking in Far East part of the world, what is the Asian paradox? Asian individuals have more bleeding risk than ischemic risk. That means that the same platelet reactivity, they have more bleeding than their Western counterparts. So this part of the world, we talk of shorter duration of DAPT and maybe a lower dose of P2Y12 inhibitors. Reasons may be that there is a higher incidence of Helicobacter pylori, intracranial atherosclerosis, and post-stroke hemorrhagic transformation. Why we need a different kind of thinking in DAPT in Eastern population. So does it always means that when you reduce ischemic risk, you increase bleeding risk? And that is why we want to navigate it through this paradox. I came across very simplified version of Asia Pacific Society of Cardiology 2020, which talks about that each patient, when subjected to PCI, should be assessed for its bleeding and antithrombotic risk. I think this is the fundamental thing. Like we diagnose MI, similarly, each patient should be categorized for its bleeding and thrombotic risk and should be mandated as a part of diagnosis so that we can plan long-term antiplatelet therapy depending upon the patient profile. Unfortunately, it is a very neglected domain. So APSC gives very simple algorithm for high thrombotic risk, coronary, vascular, and disease, CVD. And if these are the components, we know there is an increased risk. And what I want to draw your attention is GFR and microalbuminuria, very neglected component in cardiology. High bleeding risk, again, ABO algorithm, and one can calculate the risk of bleeding. Any organ failure, whether liver or renal, amounts to a higher risk of bleeding. Simple, another way to look at it is diabetes, CKD, and advanced age. They are common in both ischemic as well as bleeding risk. Small stent diameter, restenosis, greater stent length, they are again more prone for atherothrombotic events. Females, they have higher thrombotic and higher bleeding risk because of their hormones, because of their smaller peripheral arteries and lower body weight. They are prone for increased bleeding risk. We should not forget, when we are doing a chronic coronary syndrome evaluation, the risk of vascular inflammation. We had a talk on colchicine, which was not impressive in long-term outcome, but I have an understanding that the patients can be profiled in three ways: platelet activation, where ASAP2Y12 inhibition, inflammatory pathways, ASAP2Y12 plus colchicine, or with coagulation cascade like COMPASS, where a revaflow can be added to a single antiplatelet. So this is a conceptual design. The latest guideline I could lay hand upon was 2024, and it talks very clearly that as prasugrel and ticagrelor is not meant for patients who are medically managed in CCS. In high ischemic risk patients, ticagrelor and prasugrel are recommended for 1 to 6 months, but as you know, there are no such trial, and that's why the level of indication is class 2B. By default, every patient should be given 6 months of DAPT, unlike ACS, where it is given for 12 months and followed by A or C. High ischemic risk patients are given DAPT, A and C, clopidogrel for 6 months. Then you can come on one of these combinations, which are 2A, ticagrelor alone, like Themis kind of data, where it is 2B. High bleeding risk patient, they will be kept for 1 to 3 months on aspirin and clopidogrel, and one can withdraw the aspirin. One can withdraw one of them at 1 month also in high risk bleeding group, and it continues to be class 1A indication. It is interchangeable. So extended DAPT 2AA, 3-month DAPT aspirin 2AA, and 1 month DAPT aspirin high bleeding risk 2BC. One should not forget aspirin, as we heard in ACS. Aspirin-free strategies are class 3 in ACS, because if you look at aspirin is the only drug which works on COX, while other drugs are working on same pathway. So I do not imagine that in acute or chronic syndrome post-PCI, we will have aspirin-free intervention. We may have aspirin for shorter duration of time. In CCS, now we are having emerging strategies and recommendations that clopidogrel can replace aspirin monotherapy. It is class 1A. CABG continues to be 1A with aspirin. In CCS patient without prior MI and revascularization, aspirin can be given 1B. So one fundamental change which is happening is clopidogrel is taking over aspirin in long-term follow-up following PCI as a monotherapy. One has to do in chronic coronary syndrome a clopidogrel responsiveness. If clopidogrel responsiveness is there, then you can continue clopidogrel after 3 months. If it is non-responder, then you can continue aspirin. So this is the basic plan and diagnosis that every patient has to have: a high ischemic, low bleeding risk, low ischemic, high bleeding, this kind of categorization to understand what kind of DAPT and duration we are doing. If we look on long-term pathways, there are 3 pathways: Pegasus, COMPASS, and HOST. Pegasus talks about the long-term aspirin and low-dose ticagrelor, and there is a relative risk reduction of 16 to 25%, but individually CV death is not reduced, but it works only in high ischemic risk patient. More the ischemic risk, more is the benefit of Pegasus TB54. If we look at COMPASS, where aspirin 2.5 and 100 milligram of aspirin was followed up, these were CCS patients in NSR. They were not AFib patients. They were high-risk patients, and it was a tertiary prevention. And once again, what we learned in Pegasus, higher the risk of atherothrombosis, more is the return. COMPASS can be equally good in PCI patient, which is often misunderstood by many clinicians. And over a period of time, up to 10 years, if you go follow these patients, post-PCI patients who are high thrombotic risk, they do extremely well with COMPASS, with aspirin and rivaroxaban 255 milligram twice a day. And COMPASS is the only trial or in long-term follow-up, which shows mortality reduction. Otherwise, the mortality reduction is not seen with DAPT. One can do COMPASS feasibility by doing a CHEST-PAC score. COMPASS does increase in relative risk increase in bleeding, but it is least in comparison to THEMIS and PEGASUS. Aspirin, we need to continue. Host exam said that if you replace aspirin with clopidogrel, you are better off. So is the host exam extended, again showing the same positive outcome at 5.8 years, that you are better off with extended clopidogrel. But mind it that these patients do not have individual cardiac death reduction. Panther is another meta-analysis showing that ticagrelor clopidogrel was associated with lower MACE. Again, the same outcome in different trial, and you can see there is 12%, 11 to 12% relative risk reduction in MACE, while NACE is also reduced by 11%. Clopidogrel long term. So this is a ESC slide support that long-term antiplatelet strategy aspirin should be replaced by clopidogrel. And this is an editorial which talks about 12% reduction. But if you look at the NNTs are very, very high, although the trial is positive, but NNTs are very, very high. Lifelong aspirin secondary prevention, we need to relook at it. This is a very interesting article, just going to be a year old, which talks about aspirin in medically managed patients. They are not PCI patients. The two trial, AMIS and SAPT, they were patients who are more than 36 months in chronic coronary syndrome, more than 50 months, and none of the parameters were significant, non-significant, non-significant. So maybe in long term, conceptually, roughly about 3 years or more, we don't need aspirin in medically managed patient. And this is more like a dogma we are following, like HDL dogma, like triglyceride dogma. So the understanding is the antiplatelet therapy do not reduce atherosclerosis. Now we are having powerful lipid lowering agents which modify the plaque, reduce the plaque events. Probably that is the reason why a long-term antiplatelet therapy may not be needed. And I got this funny statement that aspirin should be given after an acute coronary vascular, much like same manner as antibiotic for infections. And this is a parallel concept, which is pill-in-pocket anticoagulation, that you have AF, give for 3 months, anticoagulation, monitor these patients, and if there is a recurrence of event, then you start. This is a controversial issue, but good food for thought. And I could lay hand upon one medically managed study which talked about that if aspirin or no aspirin, there is no difference in event and all-cause death, but statins make a difference. So, ladies and gentlemen, there is a rethinking, reappraisal about aspirin in long-term follow-up in medically managed patients, how we will apply on acute coronary syndrome, on chronic coronary syndrome, PCI patient. I don't have an answer. There is a concept of DAPT, Asset Japan, which talked about feasibility of prasugrel in low-risk Japanese patient. They give aspirin only for a day on the day of PCI, unlike Neo Mindset, where it was given for 4 days. Loading dose of prasugrel was 20 milligram, and then it was followed up for 3.75. But mind it is Japanese population who has got different atherothrombotic and bleeding risk profile in comparison to Western population. So we call it DDAPT, where single drug is given, and that too on a reduced dose. What is a unifying hypothesis? This is last week, host BR. It talked about that in high bleeding risk patient and low bleeding risk patient. In high bleeding risk patient, 1 month DAPT is inferior to 3-month DAPT, and without high bleeding risk, 3-month DAPT was non-inferior to 12-month DAPT, justifying that whether irrespective of DAPT, irrespective of bleeding risk, DAPT should be given for 3 months, which is contrary to current recommendations of the guidelines. So this article, this study projects that the standard for antiplatelet therapy should be 3 months. It contains both acute and chronic disease patient. So I'll end up that we have to define the ischemic versus bleeding risk. We have to individualize versus a default 6-month strategy. SAPT is coming up, and timing depends upon bleeding risk. And tertiary care, clopidogrel is coming up as a maintenance therapy of chronic coronary syndrome in post-PCI group. And this is class 1A. That is one big change. And I think we have to create a uniform atherothrombotic and bleeding risk scores, unlike there are multiple plethora of scores, and each trial and study is taking into account a different scoring system. That's why there is no uniformity in the data. So the challenge to us is creating something like risk profile in ACC-AHA risk calculator, where there is a geographical distribution, also a score-like score, where there is a geographical distribution also, unless we create a unifying atherothrombotic as well as bleeding risk score, this heterogeneity of data will keep confusing us. I'll end up that literature speaks with everyone individually. I have tried to dig out some of the finesses of antiplatelet therapy in acute coronary syndrome. I am sure we will individualize and work hard before starting rather than bleeding patient and trying to manage antiplatelet therapy, which is a nightmare to interventional cardiologists. Thank you very much.
Thank you, Professor Akawala, and excellent speak. I think the other co-chair is not online, so I to chair this session. I think next topic is about the test for ACS, and this topic is the test for coronary syndrome. The topic is a little similar, but a different situation. So, is there any question from our expert?
Yes, I have a question or comment. Dr. Rajiv, it was very, very nice presentation. I love to be always in the DAPT phenomena, because I am also an interventional cardiologist, and I see most of the time chronic coronary syndrome patient as well. The thing that I'm confused about, that how to deal those patients with the chronic coronary syndrome that are managed medically initially. For example, if you have started DAPT for 1 month and they do remain stable and you are planning only medical management, and they are found to be a low risk for coronary artery disease. So how will you manage such patients? Will you continue DAPT, or you will stop DAPT after 1 month and then you continue single PT, be that clopidogrel or aspirin?
You see, whether it's a very interesting question and day-to-day clinical problem. And the answer lies in scoring a patient, whether it's acute and chronic. If you look at Charisma trial, clopidogrel didn't do benefit until less the atherothrombotic risk is more. So the DAPT comes only in patients who have higher atherothrombotic risk. Diabetic patient, polyvascular disease, peripheral arterial disease, and most often neglected by intervention cardiologists is EGFR and urinary albumin, which are very strong markers of vascular dysfunction. And if you demonstrate that, then there's a high vascular risk patient and they need to be on DAPT for a longer duration of time. And in chronic coronary syndrome, a single antiplatelet like clopidogrel will do wonderfully well. It is class 1A now, replacing surprisingly aspirin and clopidogrel in chronic coronary syndrome on medically managed patients. Both are class 1.
What I think so, that replacement is definitely, there's a decrease in the risk of the GI bleeding, which is associated with the aspirin. we have seen that aspirin is in the scenario for the last 30 and 40 years maybe. But because now GI diseases are increasing and the patients are more at risk of the GI bleed, and versus the clopidogrel, they are the less risk of the GI bleed. Now it has been more preferable in patients with the chronic coronary syndrome as a single PT as compared to the aspirin.
I agree. I agree.
Thank you, Dr. Raji.
Thank you. Pleasure meeting.
Question on that. And the question is asked about the short death in North Asia population. I just want to say in our East Asia, we maybe use short death in high breathing risk group, maybe only 1 month. And then maybe we also use de-escalation strategy. And how about this de-escalation or short death are used for South Asia population in India or Pakistan? Can this expert can answer this question? Yeah,
It's offline now.
if they okay, we move to the next topic. I will invite Dr. Lubis from Indonesia. He will give our the topic of no aspirin or grade in coronary syndrome receiving oral anticoagulant. Dr. Lubis, please.
Okay, good afternoon, Vice President, Asian Pacific Society of Cardiology, all professor and all doctors. Nice to meet you. Let me presentation my topics about no aspirin and clopidogrel in chronic coronary syndrome, receiving oral anticoagulation, pro and contrast. For introduction, CCS are the range of clinical presentation or syndrome that arise due to structural and or functional alteration related chronic disease of coronary arteries and or microcirculation. After PCI for CCS, the DAPT consisting of aspirin and clopidogrel is recommended to reduce risk of stent thrombosis and MI compare with aspirin alone. Oral anticoagulation may be considered when antiplatelet agents are not tolerated and if the risk of bleeding is not high, or in CCS patient with concomitant long-term indication for ORCH. Successful introduction of direct oral anticoagulation DOACs for stroke prevention in atrial fibrillation for prevention and treatment of venous thromboembolism has renewed in the interest of ORCH for patients with CAD. So, what is the rational use of antiplatelets? We know there is 2 cases that presented before in ACS and CCS. In CCS, we can see the use of antiplatelets can reduce the stent thrombogenicity and prevent stent thrombosis. And we can see in the stent implantation, we can prevent the iatrogenic dissection in distal embolization. In ACS case, we can reducing thrombosis burden and flow obstruction. And in the after PCA, we can see the benefit of the DAPT from one is local, prevent the local ischemic events, prevent the plaque progression and destabilization, prevent of systemic ischemic events, and unfortunately, sometimes it can be bleeding and intubation. And what is the mechanism action of antithrombotic drugs for CCS? We know that there is 4 DOACs direct oral anticoagulation. There is fondaparinux, apixaban, edoxaban, rivaroxaban, and tirapiban. It can inhibit the X1 factor that inhibit the conversion fibrinogen to fibrin and inhibit the conversion conversion of thrombin and prevent the clotting in the patient. This is some the anticoagulant drugs for CCS. We know the warfarin, apixaban, rivaroxaban, dabigatran, and apixaban. Sorry. We can see the removal with 4 hours of hemodialysis, apixaban 7% and rivaroxaban 1%, and the lower hazard ratio for prevention stroke to warfarin is have the dabigatran, and the major effects of major bleeding referring to warfarin is apixaban than others. So, which one patient of CCS, chronic coronary syndrome, need the anticoagulant? We can see the guideline of chronic coronary syndrome in 2024. Patient with CCS with long-term indication for OH and AF atrial fibrillation with therapeutic dose of AKI alone or preferably of DOAC alone. This is class 1B. And in patient, indication for oral anticoagulant who undergo PCI, initial dose aspirin once daily is recommended. This is class 1C. And in patient eligible for oral anticoagulation, DOAC, unless contraindication, is recommended in preference to vitamin K antagonist. This is very recommended class 1A. After uncomplicated PCI in CCS patient with concomitant indication for oral anticoagulation is early cases of aspirin before 1 week and followed by stop of oral anticoagulation and clopidogrel up to 6 months in patient not at high ischemic risk or until 1 year or 12 months at high ischemic risk. We will discuss which one patient with high ischemic risk, which one low ischemic risk, and followed by oral anticoagulant alone. And continuation of aspirin up to 1 month after PCI, in addition to oral anticoagulant and clopidogrel, should be considered in high ischemic risk patient. This is class 2A. And when concerned about high bleeding risk, prefer over concern about stent thrombosis or ischemic stroke, we can add rivaroxaban, DOAC, direct oral anticoagulant, 15 milligrams daily should be considered. Preference rivaroxaban 20 milligrams daily for the duration of concomitant antiplatelet therapy. So, how about the patient CCS with atrial fibrillation? Patients with atrial fibrillation requiring OAC, oral anticoagulant, are at risk for thromboembolic and bleeding events. The DOAC have all demonstrated at least non-inferior efficacy compared with warfarin for prevention, but they have benefit 50% reduction in intracranial hemorrhage. Current guideline recommended triple antitherapy antithrombotic consisting of the DAPT double antiplatelet with clopidogrel plus on oral anticoagulant agent for a short, very interventional 1 week time frame, followed by dual antithrombotic therapy with clopidogrel plus OH for up 6 months for CCS and 1 year or 12 months for case setting acute coronary syndrome, respectively. This is the class A1, very recommended. And what does the guidelines say about patient CCS without indication for oral anticoagulation undergoing PCI? For the first time, we must assess the bleeding risk. We can discuss later about bleeding risk. So we can stratify the patient non-high bleeding risk and high bleeding risk. In non-high bleeding risk, polypharm, we can give aspirin and clopidogrel until 6 months. In non-high ischemic case, we can give the aspirin and clopidogrel until 3 months and the DAPT. This is class 2B guideline. So how about the high ischemic risk patient? We can give aspirin and clopidogrel until 6 months. This is different for setting ACS in 1 year or 12 months. And or we can give the aspirin and ticagrelor or combination aspirin and prasugrel until 6 months. And how about the high bleeding risk? In default, we can only duration until 3 months. Combination aspirin and clopidogrel, class 1. After 3 months, we can choose one of them, aspirin or clopidogrel. This is class 1. So, what is the recommendation for oral anticoagulation in atrial fibrillation? From ESC guideline to 2024, we can recommend it direct oral anticoagulation, DOAC, are recommended in preference to VKA, vitamin K antagonist to prevent ischemic stroke. This is class A1. And switching to DOAC is recommended for eligible patients that have failed to maintain an adequate time of therapeutic strength of VKA, TTR, below 70% to prevent thromboembolism and intracranial hemorrhage, with target INR, international normal ratio, 2:4 to 3, recommended for patients with AF prescribed for KA. And adding antiplatelet is harmful to anticoagulation in patient atrial fibrillation and which receiving the DAPT. This is class 3B. This is harmful, not recommended. So I will tell you about bleeding risk. How to assess the bleeding risk in patient with CCS. Let's discuss. No, this is Arch-Javier scoring. Not scoring this criteria. This is major criteria, minor criteria. The major criteria is blue dot. You can see that bleeding diastasis, receiving oral anticoagulation, planned surgery on the APT, low platelet count, thrombocytopenia, liver disease, active cancer, and the middle criteria like this renal dysfunction, EGFR below 30, anemia, hemoglobin below 12, below 11, and age above 75 years old. This is minor criteria. And how we can see the patient have high bleeding risk if the patient at least one major or two minor criteria. So is two minor is high bleeding risk or one major is high bleeding risk. This is application in our Apple application. We can count the Arch-Javier to evaluate the bleeding risk. And benefit of individuals antithrombotic therapy? No. We can also assess the thrombotic risk in patient or ischemic risk patient. This is from the ESC guideline to 2023. We can stratify ischemic risk or thrombotic risk from low risk to high risk or severe. Low risk is not meet the moderate and high risk. Moderate risk is diabetes mellitus, prior MI, PAD, CKD, and high risk so many criteria like more than 3 stents, more than 3 lesions, the total stent length above 60 millimeters, left main PCI, CTO, and bifurcation with 2 stents. This is from the new guideline of CCS, how to assess the thrombotic risk from the ESC guideline. We can see the risk enhancer. The diabetes mellitus require medication, history of recurrent MI, any multifacial disease, concomitant systemic inflammatory and or automatic disease, and related procedural or stent related aspect, at least 3 stents implanted, at least 3 lesions treated, total stent length above 60 millimeter, history of complex revascularization like left main, bifurcation stenting with 2 stents implanted, CTO or stenting at least patent vessel, and history of stent thrombosis on antiplatelet treatment. No, so we can see the higher bleeding risk, so higher major adverse cardiovascular event. We can see from the curve, the red line is non-high bleeding risk. And sorry, the red line is high bleeding risk and the blue line is non-high bleeding risk. We can see the red line more than the blue line. This is the more cardiovascular death, MI, stroke, and bleeding. No, individualizing the double antiplatelet choice, complexity and bleeding and ischemic risk. We can balancing of bleeding and ischemic risk. We can see there is a predictor of ischemic like diabetes, smoking, ACS, CKD, PAD, and others. And the predictor bleedings like age, CKD, cirrhosis, cancer, transfusion, history of oral anticoagulation. We can stratify the patient from high ischemic risk, low bleeding risk, high ischemic risk, high bleeding risk. Like this high ischemic risk, high bleeding risk, we can stop aspirin and selection of P2Y12 inhibitor based on VFT or genotyping the patient. So what's the next? We can do the de-escalation or increase intensity of platelet inhibition. If the high bleeding risk, we can de-escalation, switching the antiplatelet, dose reduction or stop. And escalation increase the intensity of platelet inhibition, we can switching, increase dose and add on other P2Y12 inhibitor. So this is some trials about bleeding and MACE compare with DAPT, double antiplatelet and single antiplatelet P2Y12 inhibitor. We can see there is the same benefit with double antiplatelet and single antiplatelet in decrease the thrombotic event, but it can same the benefit of single antiplatelet with P2Y12 inhibitor with double antiplatelet. So we can reduce the bleeding risk by single antiplatelet by P2Y12 inhibitor. There is the master trial in high bleeding risk patient undergoing PCI. In high bleeding risk patient free from recurrent ischemic event at 1 month after stop double antiplatelet was associated with similar NACE and measure and lower bleeding rates compared with standard DAPT, double antiplatelet, regardless of PCI or patient complexity. So from this trial, we can have a take-home message that single antiplatelet with P2Y12 inhibitor, it's same with the double antiplatelet, but have the lower bleeding risk with single antiplatelet compared with double antiplatelet. This is the ischemic risk spectrum and bleeding risk. We can tailor risk stratification by the APT score, Paris score, PZS, the APT score. So we can decide which one the high ischemic risk, high bleeding risk. If the patient high ischemic risk, we can do the prolonged double antiplatelet or prolonged P2Y12 or monotherapy. If the patient high bleeding risk, we can choose short the double antiplatelet, early P2Y12 or monotherapy or the escalation. So what is the guideline recommendation? Sorry. Administration P2Y12 inhibitor before assessment of coronary artery, it have the benefit and disadvantage. The benefit is periprocedural MI, reduce the periprocedural MI, reduce the early stent thrombosis, reduce ischemic event when waiting for invasive management, reduce need for bailout GP2B3A inhibitors, and maybe sometimes increase the disadvantage, risk of bleeding if emergency surgery is needed, procedural bleeding risk, and day of hospitalization. So what is the strategy to reduce bleeding risk in first 12 months after HES? We can assess for the first type is high bleeding risk. In high bleeding risk patient only, we can use double antiplatelet after just 1 month. And in high bleeding risk and non-high bleeding patient, we can continue after until 3 months double antiplatelet or 6 month antiplatelet. After 6 months, we can see this chart. We can choose P2-tap inhibitor or aspirin monotherapy. And how is the strategies, the escalation double antiplatelet? Potent P2-tap inhibitor based DAPT, we can choose combination aspirin plus prasugrel or aspirin ticagrelor. So in this escalation, we can change from potent P212 inhibitor to clopidogrel or combination aspirin or clopidogrel. This is the guideline of ESG, ICS 2023. We can see the antithrombotic strategy beyond first 12 months after HES. Default is aspirin monotherapy for all patients without contraindication, and long-term double antithrombotic. We can add anticoagulant in this case, rivaroxaban with small dose, 2.5 milligram BI2. And we can prolong double antiplatelet, this class 2A, and we can add P2-tap inhibitor. Add a second antithrombotic agent to aspirin for extended long-term secondary prevention in patients with high ischemic risk and without high bleeding risk. This is class 2A. And P2-tap inhibitor monotherapy, this class 2B, we can use in P2-tap inhibitor as an alternative to aspirin monotherapy for long-term treatment. This is from the guideline atrial fibrillation 2004. We can see in the CCS case, this is the lowest, CCS uncomplicated PCI, oral anticoagulant plus P2-tap inhibitor, aspirin plus aspirin class 1, just 1 week. After 1 week, we continue oral anticoagulant and P2-tap inhibitor class 1 until 6 months. We can see this chart. And until 6 months, only oral anticoagulation use. This is class 1 until 1 year. And how about the CCS with high ischemic risk? In 1 week, we can use oral anticoagulation, P2-tap inhibitor plus aspirin. This is class 2A. And after 1 month, we can use oral anticoagulation plus P2-tap inhibitor class 1. And after 6 months, it's the same with uncomplicated with high ischemic risk, only oral anticoagulant. This is class 1. Stable CCS, only oral anticoagulation. And oral anticoagulation and antiplatelet combination increased bleeding risk, and major bleeding is associated with earlier mortality, should therefore be avoided when possible. And from the RZD, double compared with triple antithrombotic reduce major or clinically relevant non-major bleeding without significant increase of ischemic risk. Recommended use double antithrombotic therapy or plus P212 inhibitor, mostly clopidogrel, after 1 to 4 weeks. From the guideline before, recommended 1 week. Period triple thrombotic therapy in CCS patient with atrial fibrillation undergoing PCI. And double antithrombotic with DOAC like apixaban, rivaroxaban, and clopidogrel for up 1 year, 12 months should be standard care for CCS patient with atrial fibrillation undergoing PCI. And additional aspirin only for limited initial period from during PCI up to maximum 1 month, 30 days in patient high ischemic risk. This is the major bleeding of DOAC, like rivaroxaban, apixaban, dabigatran. We can see from the curve, rivaroxaban have the incident of bleeding than others, than apixaban and dabigatran. This is the antithrombotic regimen in patient with acute coronary syndrome and indication for oral anticoagulation. Like the guideline before, until 1 week, we can see the triple, the DAPT and NOAC. And after 1 month, we can use SIPT with NOAC class 1. And after 1 year, 12 months, we can use NOAC monotherapy class 1. It's the same with strategy to reduce ischemic risk. This is how to rate dose reduction criteria for NOACs. From dabigatran, we can no dose reduction criteria, but 2 dose evaluate 150 milligram and 100 milligram, and in rocket IF in rivaroxaban 20 to 15 milligram with CRCL 30 to 49, and aristol apixaban we can reduce from 5 to 2.5 milligram. We can consider if age above 80, body weight is below the 60 kilogram, and serum creatinine above 1.5 milligram per decimeter. And endoxaban we can reduce from 60 to 30 milligram. This is the antiplatelet strategy. This is in East Asian. East Asian, we can see the difference between HS patient and CCS patient. In HS patient, we can assess for the first time high bleeding risk. Is yes, high ischemic risk? Yes, we can use aspirin clopidogrel or fix in 1 month until 6 months. And after 6 months, we can choose clopidogrel or aspirin. And in high ischemic risk, we can choose the combination aspirin and ticagrelor or aspirin and prasugrel in high ischemic risk. In no ischemic risk, we can in 1 month we can choose combination aspirin and ticagrelor or aspirin or prasugrel. And how about the CCS patient? This is differentiate in patient post-PCI and non-revascularization. In high bleeding risk in PCI, if yes, we can choose combination aspirin and clopidogrel until 3 months. After 6 months, we can choose one of them, clopidogrel or aspirin. In high ischemic risk, in high bleeding risk, and high ischemic risk, we can choose combination aspirin and clopidogrel or fix. So the newest from European Society Congress in 2025, the aquatic trial, assessment of quitting versus using aspirin therapy in patient with stabilized coronary artery disease after stenting who require long-term oral anticoagulation. This is from randomized double control trial from patient on oral anticoagulation plus minus single antiplatelet and history of stent implantation above 6 months and patient with high antithrombotic risk and patient stratification stadium A and B, and stadium A is OAC and combination oral anticoagulation and SIPT, and B stadium B in just oral anticoagulation alone, and patient randomization OAS plus aspirin 100 milligram, OAS plus placebo. So the result is the trial was prematurely stopped after about 2.2 years because high number of deaths and aspirin group. So from this research in CCS patient at high atherothrombotic risk, adding aspirin to oral anticoagulation increase major cardiovascular events, mortality, and major bleeding. So it's not recommended to add the aspirin in patient receiving oral anticoagulation. So, the summary choice of antiplatelet should be based on careful review and balance between risk of bleeding and risk of ischemic. Antithrombotic therapy is personalized treatment, which will bring the most benefit in the patient. Patient receiving oral anticoagulation can be continued with clopidogrel up to 6 months in non-high ischemic risk and up to 12 months in high ischemic risk. And CCS patient, adding aspirin to oral anticoagulation increase major cardiovascular event and mortality and major bleeding. So for take-home messages, we can choose the P2 inhibitor to receiving oral anticoagulation to minimal risk of bleeding and minimal the major cardiovascular event. Thank you so much. Good afternoon, all doctor and professor and others, doctor. Sorry, I cannot hear. Sorry.
Hi, Andy.
Yeah, hello.
Hi. This is
Hi.
Kumar from Pakistan. Yeah, it was very nice presentation, and always is a difficult task to switch between the antiplatelets and oral anticoagulants in patients who have undergone the PCI and also carry the risk for atherosclerosis or atherothrombosis. The one thing that I was curious about aquatic study that you showed in the last, that if you add aspirin to oral anticoagulants after 6 months, it was a study done that showed the increased risk of major bleeding, or they started aspirin. Yeah, aquatic at the last slide, second last slide, I think so. Second last.
This one?
Second last. Aquatic. Yeah. This one. Aquatic.
Okay.
Aquatic study.
Okay.
So, based on the aquatic study, you said that.
Oh, sorry. Okay.
Yeah, this one. Yeah, thank you.
Sorry.
So, based on this study, what I assume so, that those patients who are at high risk of the thrombosis, if you add aspirin to oral anticoagulants, they do bad. There is increased risk of major bleeding.
Can you repeat your question, sir? I can.
No
Sorry.
worries. Just based on this study, aquatic trial,
Okay.
what do you think that those patients who are at risk of the thrombosis, that's why they are on oral anticoagulants, if you add aspirin to them, so there will increase risk of the bleeding, what you are saying, major bleeding?
Yes, major bleeding, sir. In aquatic
Yeah.
design.
So they do have taken the patients who have the history of prosthetic valve or no? How many patients of them had a history of prosthetic valve implanted in these patients?
This is about 400 patients from this research in aquatic design. I'm sorry. Wait.
Is there any question?
Thank you for this.
It's about
Okay, it's time is limit. So
about aspirin 430 patient and placebo and 38 patient from totally 872 patient, and the hazard ratio is 1.53. Means at flow after 2 years, patient have so many major cardiovascular event, high bleeding risk, so the research was stopped after 2 years.
maybe
Oh.
the elevated MACE risk may be related to breathing. Yeah.
Yeah.
Okay. So time is limited. So the next topic is I will speak the preventive PCI. So okay. Let me show my slide. So actually from Taiwan, today I will discussing IVS OCD guide preventive coronary intervention for non-limiting vulnerable plaque. The background, we all know most ACS event caused by non-flow-limiting rupture plaque. Traditional PCI focus on obstructed region, yet not vulnerable plaque can rupture unexpectedly. IVS OCD image allow detail of structural vulnerability beyond angiography. These are my outline today. First, I will discuss IVS for vulnerable plaque, then OCT for vulnerable plaque on the preventive PCI guide by intravascular image. For IVS image, vulnerable plaque can be directly identified by low attenuation signal, which indicate the RPDP code by VHIVS allow us to characterize the necrotic code composition. According to prospective trial definition, stenting fibroadenoma TICFA was defined as a necrotic code. Necrotic code reach over 10% plaque without clearly overlying fibrotic tissue, and with a plaque burden of at least over 40% seen on 3 or more consecutive image. This is a definition of by prospective trial. And let's see the prospective trial. Nearly 700 patients with ACS were followed for 3 years, and about 20% patients experience MAS. And this study conclude 3 imaging features: TICFA, plaque burden over the first TICFA, the second is plaque burden over 70%. The third, minimal luminal area less or equal to 4 millimeter square was strong predictor for adverse cardiac event. So the other study, the atheroma IVS, also enforce this finding, and it also point out the large TICFA were associated with significant higher cardiac event than with small TICFA or non-TICFA. So the other important study is prospective 2. Prospective 2 provide another tool. We can see the near infrared spectroscope NIRS can detect lipid-rich plate. Or NIRS was defined a maximal lipid core burden index over 4 millimeter. The value was over or equal to 325. That indicate lipid-rich plate. So we have from IVUS, we have a very some tool like this. We can see directly see the low attenuation signal, and then we can use VHIVUS to see the necrotic code. And another tool was NIRS. We can see the directly see the lipid-rich plate. So this is from IVUS study and the IVUS tool. And for OCT image, we can identify vulnerable plate with remarkable precision. The thick bar was defined by a fibrous cap thickness less than 65 microliter, and the lipid arc greater than 90 degrees, and the macrophage accumulation. This definition are from the data from the autopsy study. Because OCT provide near histology resolution. And then we can see the clinical study. This study is a clinical study. It enrolled nearly 1,000 patients with LDL less than 50% stenosis. And they are this patient will follow for 1 year. And from this study, we can find the small minimal luminal area and the thin fibrous head and the large lipid arc over 180 degrees, the macrophage accumulation that will have a significant higher rate of adverse cardiac event, highlight the prognostic over the OCT image. So this evidence lead to the concept of preventive PCA. So the objective is here to stabilize the high-risk plate before the plate rupture. And the strategy was to use stent implantation to identify intravascular image. And the target was non-flow limiting, but the high-risk plate detect the IVUS OCT. So trial published in JACC 2020 was the first randomized study to explore the concept of preventive PCI for vulnerable plate. It includes 182 patients. I would like to point out the inclusion criteria of a vulnerable plate was simply by IVUS plate burden over or equal to 65%. This definition is only to define the vulnerable plate. And for this patient, they will be treated by bioresorbable vascular scaffold (BVS). However, the final outcome either target lesion failure or the main significant difference. Did not show any benefit therapy. However, in recent years, the PREVENT trial published in the Lancet 2024, the study include 1,600 patients. This was different from the previous study. We can see the definition of variable plate was more stringent in this study. The variable plate was defined as lesion at least two of the following four features. The first one is the minimal luminal area, less than 4 millimeters square, and the plate burden was more than 70%. And the third feature was a lipid-rich plate noted by NIRS. And the last one was compatible with syncap fibroadenoma definition, either by Evers or OCT. So this study, the definition of variable plate was more stringent than previous study. And the treatment is also a little different because the initial recruitment period, bioresorbable vascular scaffold was still used in daily practice. However, after the withdrawal, then everolimus eluting metal stent was replaced for standard treatment in this trial. So we can see the 2 years follow-up, the composite, the primary composite endpoint, like cardiac death, target vessel MI, ischemia-driven target vessel revascularization or hospitalization for unstable or progressive angina during the follow-up period. The primary composite endpoint at 2 years, the only 0.4% in PCI group, and in medical group, the event was 3.4%. So the absolute difference was 3%. And the so many different. So we also can see in the 2 years, the difference is significant. But in the extended follow-up, even 7 years, the difference was still significant. So the PREVENT trial tells us the maybe preventive PCI for variable plate will be benefit for some patients compared with optimum medical treatment. And we can see the subgroup analysis is very interesting because at 2 years we cannot see the difference of BBS compared with metallic stent. However, in the maximum follow-up, we can see the metallic scaffold have a better long-term outcome than bioresorbable vascular scaffold. This is a subgroup analysis. So I think this is only one study, PREVENT trial, can tell the benefit of the preventive PCI is better than optimal medical therapy. So the concept was still controversial, and all the guidelines did not recommend this treatment because we still lack more long-term outcome data, standard criteria for high-risk plate, and the cost-effective was not be evaluated. Start in the potential risk like stent thrombosis or DAPT-related bleeding. We should still consider some patients, especially we have discussed some patients have a high bleeding risk than ischemia risk. So still have many issues we have to clarify and more evidence we share to to get to more evidence to prevent this preventive PCI advantage. So this is the last slide. I will summarize. Most ACS origin from non-obstructive vulnerable plaque, and we should use more intravascular image to identify all the lesion, to know the plaque composition and how to treat the plaque, to get more better long-term outcome. And the preventive PCI, I think we can see in the recent study prevent trial, we can see they show a different significant difference in beneficial outcome for vulnerable plaque if you can identify it correctly and treat metallic stent, even resolvable stent, still have some benefit. However, the guideline have not been recommended, so we still need more evidence to prove the concept. Thank you. This is my best slide. So is any question for my speech? I think I just I did not delay too much.
Dr. Lee, just a small question from my side. Actually, those patients who are labeled as angiographically non-obstructive lesions is very sometimes dubious because most of the time it is eye-based. So one person is saying it is non-obstructive, another saying it is obstructive. It's very difficult sometimes to justify to be as actually a non-obstructive lesion. SEC based, it says when the lesion is less than 50% of the luminal narrowing, it is labeled a non-obstructive. But to me, the morphologically hazy presence of haziness, presence of ruptured plaques angiographically, or only the luminal narrowing, I think so that should be defined properly in the future coming studies, that what you exactly say angiographically non-obstructive lesions. What do you say about this one?
The angiography could not to define the lesion character. You maybe some very experienced angiograph cardiology maybe can identify, estimate the haziness is like a vulnerable plaque. However, we should have more scientific evidence to prove, not just angiography. So I think this is the era of intravascular imaging. So I don't know. I'm not sure in the Pakistan, do you use intravascular image for most of PCI procedure or just a little penetration?
Not most of the not for most of the PCI patients, as where I do work, it is one of the largest primary PCI center in the country, because we always take those patients who are highly thrombotic lesions or totally obstructive lesion. But we do intravascular imaging in few elective cases, but not in the acute coronary settings.
In Taiwan, in the past year, maybe 4 or 5 years ago, we did not use intravascular image for all the ACS patients. But in recent years, more and more evidence from the intravascular images, even for ACS patient or CCS patient. So now more and more patients, even with more and more patients with ACS, we may be use OCT or iris to see the cause of his ACS. So there are signs, and there are more interesting findings. You can see the peripheral erosion, maybe in some patients with ACS, but you may see the patient maybe from Minoka, but you can from the OCT image you can see the peripheral erosion. But so some interest finding from the intravascular image. So maybe in the future, I think the guideline will be changed in the future. If some ACS patient, I think if the ACS patient is very simple, you may not use intravascular image, but some most of ACS patient maybe we can use intravascular image to define the treatment strategy. Because you just see the peripheral erosion, you may need to use the stent. You can use DCB or just use thrombectomy, then use optimal medical treatment. But you can, if you see the plate, the composition, maybe more calcium, more dissection, you maybe use the stent to treat the ACS. So I think the intravascular image will be should be very important for ACS patient.
Okay, thank you.
I think the time is limited. But my co-chair, Dr. Seo, is not online.
There's another question on the chat board.
Okay. Oh, how about large? Okay, we can see. How about large break volume? Okay. I think Professor Lin provide another important question. He point out the large break volume or TICFA in non-obstructive coronary lesion in ACS. So the concept is preventive PCI. So if you believe the prevent track, you maybe do stenting to treat this lesion. Because this lesion is not prevalent, the TICFA, maybe it will have a event in the future. So if you believe the prevent track, you can to treat the lesion. However, I had mentioned before, now no guideline recommend the preventive PCI. Even preventive trial see a benefit of PCI to treat. So actually, maybe we can see more evidence in the future. So I think because the co-chair Dr. Seo is not online, maybe Professor Lee will give us closing remark.
Okay, I think this is a very interesting section, and also just within the target of our webinar. It's pretty much debatable issues in these issues. So talking about the beta blocker in patients with acute coronary syndrome without heart failure, and colchicine in ACS and CCS, and even the time frame for the DAPT in ACS and CCS. And the most repercussion actually is the last topic. Dr. Lee has been talking about the preventive PCI in those patients with non-obstructive coronary lesions in ACS or non-ACS. I think we do have a very good discussion in this web conference. and we converge the current concepts from Asian Pacific areas. I think everybody will learn a lot from today's lectures and also all the Q&As discussions. I believe that we can learn a lot. We will think about it. So what's the most important is think individually for every patient. And that's a very difficult question actually. I think nothing. I think there's no really established data for all these issues, but we just keep learning and more and more clinical trials coming out. Thank you for Professor Lee's very leading nature for this chairmanship, and we'll also thank you for all the speakers to give us the very illustrative lecture for us. Thank you all. Thank you all.
Yeah.
Okay.
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 Thank you, Professor
Thank you,
Lee.
Prof. Thank you, Doctor.
Thank you. Thank you. Have a good day.
Okay.
Goodbye.
Bye. Okay. Thank you for everybody.